Welcome back, everybody, to episode 28 with Dr. Hongfei D. Dr. D is a new type of physician that is focusing specifically not on different types of care, but different modalities of healthcare systems. Doctor, welcome to the show.
Hi, Jacob. Thanks for having me.
The name of your business is Paradigm Primary Care. And that's very aptly named because as we're going to go into this episode and talk about this new way of approaching healthcare, tell us a little bit more about your view on the healthcare system and why you chose to start your own practice.
Wow, so that's a really good question. The reason I chose Paradigm is because I think of it as healthcare redefined, restructured, because that's pretty much my current view of healthcare right now is it needs restructuring. I feel like it's a broken system, and I'm sure I'm not the only one that thinks that way. Everything from over the last 2 decades, how much insurance have become involved in the healthcare system, how much administrative costs have risen, how much healthcare costs have risen, and how much access patients have lost. It's not correlating very well. You're seeing the government spend more on healthcare every year. We're the number one country in the world. We spent the most on healthcare. However, over time again, we are ranked low with how healthcare is given out. I can only speak from a primary perspective because I am a family doc. My education's in primary care, and even in that aspect, I feel there's something going on. It's not adding up. And that's why I decided to finally step away from corporate and insurance-based medicine and pursue this endeavor.
Most definitely. Now, people who are going to listen to this are going to think, what exactly are you doing that's different and why is it better for me? How would you answer
Mm,
that question?
That's a very good question as well. How is it different? The basis of Paradigm is going back to old medicine, where you have your own private doctor who knows you, who knows your family. Their main priority is your health and your family's health, where time is not a limit, neither is money. And access, there's no limitations to your access with your physician, which seems to be non-existent nowadays. And in order for that to succeed in this current atmosphere, I had to step away from insurance. So Paradigm itself, the clinic is completely cash pay, it's membership based. I'm not taking any incentive from insurance companies. I'm not taking any incentives from the health systems. This is strictly a mom and pop clinic where my patients pay a monthly fee with full access to me 24/7, as it should be. If you're sick on a Saturday evening, you should be able to call your doctor who knows you like the back of their hand and explain the situation rather than being sent to the ER unnecessarily or go to an urgent care where you're seeing someone who knows absolutely nothing about your health to manage something that could be either non-life threatening or vice versa, could be life threatening, which your own doctor, if you spoke to them for 30 seconds, would know right off the bat. So, for us, we're not time restricted. My patients get anywhere from 30 minutes to an hour or even longer per visit. There's no access restriction. My patients always get same day visits with me directly. They can reach me by email, phone, or through our app 24/7, 365. And my patients get a one-on-one treatment as well as all their lab work, their injections, their biopsies, their stitches, everything done under one roof without being like a referral bus, which is also a common practice these days. Primary care, the scope of practice is very big, but with the onset of insurance and reimbursement and specialties, a lot of times, I'm sure as everyone listening is well aware, you go to see your primary care doc for 5 minutes, you leave there with nothing addressed but 5 other doctors you have to see, all of which could have been addressed by the primary in 30 minutes or in an hour visit. So we're really saving our patients time. We're really working on their health and prevention. We're getting to the root cause of their health issues rather than here's 5 pills, I'll see you in 3 months. So that's basically what our practice is. It's a new paradigm. It's how it was 30 years ago.
Sometimes the best paradigm is going back and taking
Yes.
some of the old and bringing in a new approach. One thing I think that's really important to highlight is that you didn't set out on your journey when you wanted to become a doctor to do what you're doing now. But as you got into medicine, as you practiced, as you saw the way the industry was and the way that patient care was, you changed your view and your perspective on how healthcare should be. Tell us more about the journey to becoming a doctor, all the time, the effort, what really goes into it, and maybe some of those moments when you realized that you needed to do things in a different way.
Our journey, all doctors' journey is a long and convoluted one. I grew up in the US, and then I looked at the track to become a physician for the US health system and education system, which is very vastly different from throughout the rest of the world. We're one of the only nations in the country where you require 4 years of undergraduate before you can even pursue medical school. A lot of European countries, Asian countries, students go right out of high school into medical school. Why? Because of the commitment, the time, the money. A lot of it is wasted throughout the whole course of the education on how much we spend here and how much time it takes us to get to the finish line. So I actually decided to go back to China because I didn't feel like I wanted to take on 4 years of time in undergraduate and another 4 years of debt that involves undergraduate. I went back to China. I passed some entrance exams and got into one of the top 3 international medical schools in China. Over there, medical school is 5 years. And after that, I did a year of general surgery internship at my hospital there and was thinking about, I love the healthcare system here. I love the training here. Maybe I'll come work in an expat hospital in Shanghai or something. Then after a year of general surgery, I ultimately decided to come back home. I didn't miss home. I didn't miss my family. And general surgery residency was tough. I felt, God bless these surgeons, waking up at 5 o'clock in the morning and not going home until 9 o'clock at night. And that was their routine. That wasn't my ambition at that time in my life. So I did come back home. I worked for a little bit and then wound up pursuing residency at Case Western for family medicine. And that's why I did my residency and I excelled there and became chief resident. In residency, I would say that's the first real beginning of the journey into the world of medicine. A lot of the major top tier residencies are in low income cities, such as Case Western Metro Health. We're looking at Johns Hopkins, Cooks County in Chicago, Cleveland Clinic. So all these training centers are in underserved areas where our prerogative as training physicians was to treat. We didn't worry about insurance. We didn't worry about saving the hospital money. We didn't worry about saving the insurance company money. That burden was never put on top of us. I remember one of our training doctors said, "You're going to see the real dark side of medicine after you finish. But right now, we don't want you to worry about that. We just want you to learn medicine and treat. So don't worry about if medicine is too expensive. We will figure out a way to get it covered. Just learn the art of managing illness." I really like that, where in residency, we were really taught a patient-centered approach to treatment without any other burdens on our shoulders. And then after I finished residency, I joined a very high-functioning private practice. This is an old school cookie cutter private practice. My mentor, who I value and I have modeled the way I practice, he was this 80-year-old South African immigrant. And in his mind, patients always came first. He was one of those guys that would stay until 6 o'clock, even at 75, 80 years old. He would never refuse a patient that walked in. Insurance, no insurance, can't pay, whether he's already overbooked or not. No patient went unseen. However, he took that burden on by giving up his time and eating the cost and taking a financial loss. But that part of my career, I realized, wow, to have that ability to make that call in real time, which I never had access to before. Unfortunately, like most private practices, that practice did get sold to Cleveland clinics, and that aspect of healthcare disappeared with that sale. So after that, I joined academics again and became a medical director to see if I can incorporate some of the things I saw in private practice into current large corporate healthcare systems. Unfortunately, with the regulations, with RV bonus healthcare, with meeting quality measures, I worked there for 3 years and realized it was an uphill fight. There was too many red tape. There was too many regulatory aspects to allow us to have a mixture of these two, the best of both worlds. I even at that time, pre-COVID, went back to Weatherhead's business school and try to, at Case Western, try to pursue an MBA to see if with that title, we can get something going. Unfortunately, COVID happened and we had to put that on hold. But ultimately, throughout those experiences, it pieced together what I wanted in medicine, what I wanted in my practice. So when my wife and I finally moved from Cleveland to Florida here in St. Augustine, I decided to join a small up and coming community health system. Up and coming means I can still go in there with my background, both academic and private practice and leadership and administrative. Maybe I can mold this up and coming ambulatory center to see if we can last ditch attempt to make both the best of both worlds. Unfortunately, 2 weeks after I joined, UF bought the health system. That wasn't something I was looking for. And I decided to finally take the leap and start Paradigm.
And it seems there's a pattern where the money is the master ultimately to the care and the service once it gets in the hands of insurance companies or private equity or groups like that, which follow traditional models of business, which is to scale as much as possible, grow profits, expand your revenue streams. So, how does a practice like yours differ? And how do you maintain high quality of care, also solving for the critical needs that your patients have?
So I think the fundamentals of that is I don't rely on insurance company reimbursement. I don't rely on how insurance thinks medicine should be practiced. I also don't rely on the RVU incentives or the quality metrics that insurance companies ultimately bestow on health systems, which bestow on the practitioner. So from a numbers game perspective, an average doctor in a traditional, like primary care doctor in a traditional healthcare setting, 3,000 patients, 1,000 to 3,000 patients, and see an average of anywhere between 20 to 24 a day. And a lot of times you would think, okay, that guarantees a patient 20 minutes. But what a lot of the general public don't know, but can know from experience is I never got that 20 minutes. I went in and got 5, but I was allotted for 20 minutes because you have to look at the administrative part of the visit when a doctor has to do chart review because there's no way they can remember 3,000 patients' names or their past medical history. They have to focus on documentation and sometimes over documentation. And by the time you actually get a face-to-face with a doctor, you get 5 minutes and you realize they're on their computer. What are they working on their computer? They're working on how to maximize so they don't have to take it home. And they have to maximize billing so they can be reimbursed to the maximum potential by the insurance companies. The last thing on their mind is 3 chief complaints you came in with because they could only probably have time to manage one. So in my business, we don't have to deal with any of those quality measures. We don't have to deal with coding. We don't have to deal with getting reimbursed with insurance companies. We have a monthly membership for our patients, and that covers our overhead. That covers my paycheck. And I can really just spend the time and focus on giving that time to my patients. It's on average, insurance companies reimburse doctors and hospitals at about 50 to 60%. And that's across the board with both for the commercial and Medicare and Medicaid. So if you think, and from a business perspective, if that fact is there and you want full reimbursement for your time as a physician, as a health system, the only way around that is either overbill or squeeze in patients. If you're going to pay me 50 to 60% for that one patient, then I'm going to fit 2 patients into that time limit, because at least then I can, in my opinion, be paid accurately with the time that was given. So without those restraints, we're free to do what the heck we want. If you need 5 minutes, if you need 30 minutes to an hour, we can give you that. And I really don't think in this current age where health is so important, get to root cause of a lot of health issues unless you spend time and see what the patient's complaints are, see what their social economical situation is, see what their family life is, see what their mental situation is. All this stuff and it takes time. And unfortunately, at my old job, we just didn't have that time.
Now, I'd like to talk about a few different case stories or just a personal experience that I'd like to get your perspective on and how perhaps your paradigm of healthcare might approach these things, but also to understand more the incentive system that's in place because I don't really think anybody understands, aside from physicians and those in medicine, how the incentive system works. Speaking from that, I do not know how it works. So I'd like to know more. But one of the stories is I was just talking to a friend of mine, and he was mentioning how when his son he came home, he was traveling and he came home and he talked to the babysitter, and the babysitter said he hasn't actually eaten in a couple days. He just hasn't been hungry. And he used to be a medic for the military, and so he did a field analysis, and he determined that his appendix is going to burst. He has appendicitis. So he takes him into the doctor, and he said that to the ER, and they spent the next 12 hours figuring out how to chart and bill properly and how to optimize and maximize billing, all the way to the point where his appendix actually burst before they did
Great.
anything. So tell me a little bit how potentially you might approach that situation and what were they doing? What is that
Right.
incentive system?
Yeah, our ERs are definitely overwhelmed, and unanimously, emergency departments have been a huge financial incentive for large health systems because of how high and how much they can bill for that 12-hour period. How we would have handled the situation is same day we would have got your friend's son right into the office, done his vitals, checked his temperature, maybe ordered stat blood work done right in the office, done a physical exam. And if a high likelihood, in my opinion, that has appendicitis, then what we would do, we would send him to the ER and coordinated call to talk directly with the ER manager versus the current ER physician to tell them our medical opinion and the urgency of the situation. Unfortunately, nowadays, with everyone running behind, short staffed, I can say from experience that all my patients get my card. So when they go into the ER, the first thing that I tell them to do is give the card to the nurse or the doctor or the PA and tell them you have a private physician that wants to be looped in into the treatment plan. And that immediately forms a link of direct communication, right? Number one reason for malpractice and poor outcomes is miscommunication, especially in the healthcare field. So right away, my patients get almost a level of urgency, knowing that they have a private doctor on their back, that people have to step up. And if a private doctor already called and say, I'm worried, have documented that they called the ER, spoke to the physician, that kind of lights a fire under the whole process. Now, what happened to your friend's son, although unfortunate, is, in my opinion, common practice now. Our ER has to put the most urgent people in place. It could have been time of the presentation. Maybe he didn't seem that urgent, or how our ERs right now are overfilled. We have patients in the hallway. Hopefully she wasn't one of those. I also think another reason for that situation is we practice right now as a healthcare system, safe medicine rather than good medicine becomes such a litigious environment that you go to the ER for shortness of breath or cough, and next thing you know, you come out with a angio and a cardiac catheterization because, number one, I'd like to say physicians are worried about being sued, but given how the health systems are reimbursed, the other side of me, the more morbid side of me feels like a lot of times you might be milking insurance. And there's been studies to show with the current reimbursement system is the insurance that forces bad practice onto health systems. So if we reimburse our ER at 60%, then we're going to upscale our billing. We're going to increase our billing. Does unnecessary procedures and tests happen all the time? Absolutely not. But does it happen? Absolutely. I think so. Maybe your friend's child was put into that mess rather than going forward and getting a CAT scan right away, getting a surgical consult. They might have ran some other unnecessary tests either to protect themselves or to milk the system. But that's just speculation.
The other one is actually my mother-in-law. She had insurance and she's had the same insurance for 8 years, but for whatever reason, there was a gap of a month in her coverage. They're switching her over to some other plan. And so she's about 74, 75. She feels like she's 30 and she acts like it, but and she's pretty amazing. But she's on 7 or 8 medications. And all of a sudden she runs out of her medications beginning of the month, actually beginning of this year. And now the medications are a few $1,000s each and she can't cover it and probably doesn't want to, right? Thinking, okay, I used to have this covered and now for just for a month, it's not going to be covered. But she has some pretty serious health things that she's dealt with. She's had numerous heart attacks. I think she has a defibrillator in and other things like that. But she's a very vibrant and alive person and dances and meditates and does things like that. For this period of time, she did not have this coverage. And so what she did is, probably like most people, she just stopped taking her medication. And we're talking about things that are modulating her heart rhythm to make sure that she doesn't get out of rhythm and out of order. And what was pretty mind-blowing is that she was quite fine, actually, for that month. She was able to not have any adverse circumstances, thankfully, and she got back on her insurance and things were covered again. But basically they said, sorry, you're going to be covered in the beginning of February. You're not going to be covered for this month. That's a little scary and potentially worrisome about the insurance system. But then there's also just that at this point, the doctors that she might be seeing are probably just optimizing so that she doesn't pass away or die at the hands of not taking something that she could have been taking, instead of trying to figure out how she could maybe take medications. And you're a doctor, I'm not. So you'd be able to give some understanding of how that process works, because a lot of people are on medications and prescriptions and things that they might have needed at one point, but now they don't need, but they're still taking them. And then it creates these kind of loops of dependence and things of that order. So how would you address a situation like that?
A very good question. So throughout my career, throughout just being a new business owner, I realized the fundamental differences between my business, insurance, and corporate healthcare. And I don't want to be cynical. I don't want to come off as a cynical doctor, but some of the stuff that I've looked into, read, when it doesn't make sense in your brain anymore, and your brain's more or less of an educated person, I like to think of myself as somewhat smart, then it doesn't make sense. And you really have to dig a little deeper and find out. For instance, because of the insurance, because of how healthcare corporations make money, we're going into something what is known as sick care rather than preventative care. Let's just put these two differences of businesses apart and look at it from a big picture. My practice is monthly membership, right? My practice success is word of mouth. If I keep you healthy, if I get you off of your medicine, if I get your blood pressure down, if I get your diabetes controlled, if I make you feel like you were 10 years ago, you're going to tell your neighbor, you're going to tell your friend, you're going to say, this is this kind of treatment, this kind of access, I've never had it before. Because it's a monthly membership and my patients have unlimited access to me, it would behoove me to keep you healthy as a patient. Because if you're not healthy, you take up my time, which is the money, which is the core of my business. So you're paying X amount of money a month. And if I can't keep you healthy and you come in 20 times and they're all free because everything's all inclusive, you just took up 20 visits of a monthly membership, which in essence, if you put time and money calculated, I lost a heck of money on you, right? So direct primary care, this model behooves the physician to keep his panel of patients as healthy as possible, so he can take on more patients, make more revenue, and provide more care. Let's look at the current corporate healthcare system structure, right? Like your mother, it seems like she has 8 medicines, and when she stopped them all, it was not life and death. Healthcare system is, they don't get paid unless you go in. And sure, your listeners have made those calls to their doctor and said, I get a sinus infection in February of every year. I know what this is. It happens every time. Can I please have some antibiotics? And they go, no, our doctor needs to see you. Why? I've been with that doctor for 10 years. Why does he need or she needs to see me? It's because the hospital don't get paid for a telephone call, right? This is where the sick care concept came in, is in that business structure, the hospital makes zero money if you don't come in. So how can you coming in, repeat customer? The cynical side of me is either overprescribed medication that require monthly follow-ups or every 3 months follow-ups, or keeping you sick. Like I said, it's a cynical part of me, but from a business structure, that makes sense. It doesn't behoove corporate medicine cure you 100%. Get to the root cause of it because they would have lost a customer. They would have lost revenue. So yeah, from your mom's experience, I don't know what the 8 medicines are. I don't know if she needed it. But the way we practice, whenever I get a new patient stepping into my office from a corporate healthcare system, is I spend that hour looking through their med list, looking through, is this absolutely what they need? And if it is it only temporary? And if we get to the root cause, can we stop it? I had this patient who was about 250 pounds overweight, came into my office with 8 medications. And the root cause, as simply put, is weight and lifestyle. At that time, those 8 medicines may be a necessity or maybe over the edge. But now, a year later, he's not on any of them because we addressed the core issue. He's lost weight. He's better his lifestyle. Doesn't need to be on blood pressure, thyroid, or cholesterol medicine. Absolutely zero. I do think there's a disconnect between the current business structure of corporate healthcare, that it doesn't make sense to cure the patients. It makes sense to use these incentives, use these quality measures to bring them back so you can, in essence, milk their insurance.
And common saying in business and in life is you must follow the incentives. And
Right.
when you follow the incentives, that's where the activities or the actions will go.
Well,
And I'm sure that there's a lot of doctors who could be listening to this and probably feel that they are simply operating within a system that forces them and mandates them to act in a certain way. But I'm sure that they also feel that they do the best that they can to provide phenomenal care. And I think one sense that I'm getting from you, though, is that usually with a new paradigm, you want to get rid of the way things are done, right? That's the view of a paradigm in our cultures, that it's a complete transformation to the point where the old is gone. But I think, and you might agree, that there are very good things about our healthcare system and the way things are run, and that every business should have a profit. But of course, we want to know how much should those profits be and what really creates better outcomes. And I think it is, without having a model like what you're bringing to the table, it's difficult to truly engineer better solutions because if, for example, the logical justification is that the healthcare industry needs higher billing, higher profits so that we can reinvest to create better medicines, there's a value in that, certainly. But if we're taking every single problem and that person that you just mentioned, sir, you need Ozempic. You have your 8 medications, but you know what you need now? You need the ninth one. You need Ozempic. You need the other, what is it, semaglutide? Is that how you say it?
semaglutide, yes.
Yeah, semaglutide. You need the next semaglutide injection. That's well, just as a small note. What is your take on those injections and those things that are coming out, and really the root of what we're talking about, and how what you're doing could become something done on a much larger scale that drives better outcomes and solutions for patients and for the world as a whole, still driving investment into medicine as it should be, but really prioritizing true patient care.
Yeah, I think we have to change the fundamentals. We have to change the incentive, like you said. My model, my incentive is to keep patients healthy. And you're absolutely right. I think doctors nowadays are born trained and born into that system. 80%, 90% of new residents go join a health system or join a community health system. Nobody finishes residency and goes, I'm going to take this huge investment and start my own practice. So they don't know a better world out there. And they are born into a world where they focus on RVU-based incentives and meeting quality measures and trying to make the hospital money. Health system is broken overall. I think the reason this is because there's lack of physicians. Health systems are buying up physicians left and right. They're buying up for territory, which is footprint. That footprint's useless unless you collect physicians. Or once they collect the physicians, they can do what the heck they want by subjugating the physicians to a huge non-compete clause and all that stuff. So it's hard for a physician to get out once they join the health system. So yes, my model is great. If I could bring every primary doc out here and to do this, and they would love it. However, a lot of us are restricted by a non-compete. We're technically owned by a health system while we're working there and owned for 2 to 4 years after we work there. Also, again, the physician shortage, right? We're looking at 80 plus thousand physician shortage in the next 10 years. Just in Florida, 17,000 estimated shortage. That's why it's so competitive for these health systems for their footprints to collect physicians. I really don't know the fix. And I think the fix has to be multifactorial. From my end, I'm hoping with this podcast, we can reach out to more young aspiring doctors. We can reach out to current doctors and give them some insight. Look, if I could do it, I'm just a regular Joe Schmo. If I could do it, you could too. And you can provide better patient care. You can give patients more time and you can make a decent living doing so. And no physician, no resident finishing residency thinks that they want to make so much money for the health system. Their main goal is to give care to patients and support their family and pay off their $500,000 in debt. So their last thought is going private. So hopefully, as more people come out from the grasp of these healthcare systems, it would push insurance companies and healthcare systems to work together and figure out a way to have a bimodal model for something like this to work. Until that day comes, sorry, they still have the corner market and they can do what the heck they want. Jacob, over the last 2 decades, physician salaries have stayed pretty much the same. The cost of going to medical school, undergraduate, skyrocketed, and the cost of the number of hospital administrators skyrocketed, and the number of money going to hospital administrators skyrocketed as well. In essence, that trajectory shows you how broken the system is. We're throwing so much money into healthcare, but the two people that should benefit the most, physicians and patients, seem to be getting any of the trickle down effect from all that money spent. And I completely agree with you. You look at any major study out there ranking the US healthcare system. Yes, we lead in technology. We lead in research. We lead in big pharma. We lead in state of the art treatment. Well, outside of that, we are lacking in everything else. We're lacking in life expectancy. We're lacking in patient access. We're lacking in so much that it doesn't make sense when we're the world's leading country in healthcare expenditure, but we are lowly ranked from a healthcare perspective international. I don't know what the fix is. I wish I did.
It would seem that potentially it's scaling what you're doing. And you mentioned the word bimodal. I think that it's only logical to have that sort of approach, this hands-on primary practice care that's similar to the model that you've seen success with some of those other doctors you worked with and also what you're doing now, where people can get a doctor who truly cares about their health and where the incentive is aligned. But when somebody needs a surgery, a life-saving treatment, brand new sort of innovation that can save their life, that does still exist. And then from a numbers and business standpoint, admin is, and you could really look at the overhead, just the general scale, because that's what it's all about right now. It's about scale and it's about recurring return visits, as you said, prescriptions, and you're scaling overhead, but you're not scaling value. And so there would need to be a merging of the two, but then there would need to be a massive healthcare transformation to go along with it to say, hey, this is what our advanced healthcare is extremely good at. And here's what our root level healthcare, the older model that is now new and improved as you're bringing it to the market, what that type of business thrives with. There would need to be a re-engineering of both and an alignment of the two. But the interests of, let's say, big pharma or other groups like that is they're extremely powerful. These insurance companies, the big pharma. So it seems to me there'd have to be some sort of model. And my wife is very inspiring to my son. She wants him to be a doctor. And ever since he was 0 years old, she's been telling him he's going to be a doctor and getting him little doctor toys and doctor books and everything like that. And you talk about the physician shortage that has been exacerbated by things like COVID and really just that the intensification of the needs of patients that occurred over that short period of time really burnt out a lot of different people. So, what other hope could you provide for people who want to be doctors? It really would seem that your type of care would need to have an inlet system for these type of people to begin to practice medicine in this new way. We approach it from a regulatory standpoint, we approach it from a legislative standpoint, and all the different ways that things would need to happen to really drive the kind of change that's necessary.
Thing we can do to incentivize more people going into medicine is showing that there is alternative practice models. There's alternative things they can do after they finish. Right now, like I said, 80 to 90 joint health systems. And you know what? If I was an aspiring medical student, I haven't decided and I went to go see my doctor now, the last thing I would do is become a doctor. You go there, you sit for 45 minutes, you go in, you see your doctor's overwhelmed. They basically barely make eye contact with you, and then they have to rush out and see the next person. And you're just like looking, you're like, no thanks. And then not to mention the debt that comes with it. I know I'm taking over your question here, but I think I wanted to make an area of focus in this podcast is here's some concept that doctors are millionaires, that doctors are in it for the money, that we're not. Your son, your daughter wants to become a physician. You need to sit down when they're older and tell them straight up, this is what you're sacrificing. And for me, it was sacrificing time, right? Education process to become a physician in the US is very long and tedious. So you're sacrificing your time. How much time on average a physician that finishes residency, combination of all the specialties, is 30 to 35. Women in their 50s and 60s. And you ask them, what was the prime of your life? 20 to 30. Good news. You just gave up your prime of your life to live in a hospital, work on education. So you give that up. And then the financial burden, undergraduate, medical school, we're looking at $300,000 to $500,000 in debt. How many professions in the US right now where you got to sign them a big fat contract where you're going to finish with $500,000 in debt before you take one pinhole? And this is where the hospitals ultimately capitalize. They know doctors have debt. They know first day out of residency, holy crap, my loans are going to start ticking. They're going to ask for repayment. So it's almost like a gambler. All of a sudden, the loan sharks are coming. Join our health system. We'll pay you a decent amount, and at least you can start paying back your loans. So financial perspective, time, your prime you're giving away. And the main takeaway from me was, I wish they told us that sacrifice of time also involved starting a family. I think that needs to be a discussion. You're too busy to start a family in medical school. There's no way you're starting it in residency. So you're looking at maybe finding a partner, having a healthy relationship after residency. And like for me and my wife, we're both physicians. We didn't start having children until I was 33 and she was close to 35. Well, all your friends in other fields are already on their second and third kid. You don't want kids? Great. This is a great profession for you. But if you want to have a family of 2 or 3, they don't tell you it's going to be tough. They don't tell you, good luck, you're probably going to start in your mid-30s. I'm very glad your child and a lot of children out there want to be doctors. I just don't want anyone to be blindsided. We are not in it for the money. Some of the doctors that you see will be paying off their loans for the next 20 years. Okay. They still work for the man, especially if they're in a health system. They're still taking home a W-2. They're just their employee. So I feel like all those negatives I discussed, they need to be addressed first before the doctor shortage can be decreased. Because right now, in my opinion, I'm sorry, even though I love my job, I don't think the limit is worth the squeeze. I finished, my wife and I still have debt. And in order to pursue this venture, I withdrew my whole 401k. It's not something, I'm not rich by any means, but this was one way that I felt the sacrifice was worth it because I was getting burned out. I was hating my profession, and you don't give up half of your life and realize, hey, this might not be good for you. You're already too committed for it. So it was either make this change or change my career, which Unfortunately, that's the poor thing. You have to tell your children, once you choose this pathway, there's nothing else that you can do. You can't go into software. You can't go into business. You can't go into investing because you spend all the time studying medicine. So that a lot, like a lot of other professions, if you feel like it's not working out for you, you can digress a little bit, take a sidestep, take a few more classes, learn a few more trades and excel there. There's only one choice for us, either take it or leave it, but you have a mountain of debt. So there's no good way. I just know in Asia, in European countries, a lot of the medical schools are subsidized and paid by the government because they know a shortage is coming. I don't know if the US will ever be that kind. Reduce the amount of time it takes. US being the only country that requires adding 4 years on top of it. Finishing residency in your late 20s is better than mid 30s. I don't know what the fix is, but I think in order to find the solution to any issue, and especially in healthcare, is understanding there's a problem. And I'm really grateful you brought me onto this podcast because it gives the general public at least an idea of, holy crap, there is a problem. So understanding it is half the fight. Now we can get our great minds together, doctors, patients, legislators, and focus on change.
So a re-engineering of that education process is in order.
I hope so. Maybe, yeah. Fix it from a financial, fix it from a duration, give more incentives, and it's going to fix itself. But until you do that, the shortage happened because the saddest thing is we anticipate the population growth. We have not increased our training positions for residents and doctors in the last 10, 20, 30 years. Instead, the fix is getting more mid-levels. That's a Band-Aid on a gunshot wound. I love our nurse practitioners. I love our PAs, but you can ask any of them and they would all agree they did not go through the same training as medical doctors. It's just a Band-Aid on a gunshot wound. And that's the status quo, even with healthcare, even with disease, is we prescribe medicines, we prescribe treatments. We don't get to the core issue. Semaglutide, like you said, Ozempic, Mounjaro, Zepbound, Wegovy. On paper, it looks great. You have all these data coming out. It reduces weight. It reduces risk of diabetes. It reduces inflammation factors. It reduces cardiovascular and kidney outcomes. At the basis of that is weight loss. It doesn't take a rocket scientist to realize at the basis of that medicine is what we're eating. It's what our weight is. If you can decrease that, of course, all these other mortalities are going to come. So this class of medicine, I love it. I think it's going to be the future, but I think it needs to symbolize what we're doing wrong as a country, especially in healthcare. Don't praise this medicine. Praise the fact that we've been treating health wrong for the last 40 years because you stop eating, you lose the weight, medicine or no medicine, your mortality, all these comorbidities are going to come down. So people ask me, oh, doc, but it's new. What happens 20 years down the line? And I say, who cares what happens 20? The lesser of two evils right now, right? It's either cardiovascular, renal disease, stroke takes you out if you continue this way, or I give you a medicine that can get to the root cause, have you have a healthier lifestyle with decreasing your dependence on food and having a better relationship with food. And then whatever comes 20 years, we'll tackle it then. At least I know I won't lose you to diabetes, right? I won't lose you to a heart attack in the next 20 years. That's the way I practice medicine. I feel like over the pandemic, over the last decade, we've been too focused on pharmaceutical involvement, insurance involvement, and less focused on the root cause of diseases. So that's why you see such a big push for functional medicine, holistic medicine. People have lost faith on traditional healthcare. People have lost faith on medications, vaccines. I do think we need to be in the middle of that. We need to combine traditional medicine with this new age of functional holistic medicine and finding the root cause, combine both. You're having a heart attack, I'm still going to request a stent. I'm still going to advise you put something in there to save your life. But after you have it, let's get you off of those 8 medicines. Let's prevent another one from happening. And that's where you draw, the holistic nature. My goal as a physician is to deal with what's already happened, but prevent the next one because there's no incentive for you to keep coming back to me. I'm
Mhm.
going to fix you. I'm going to keep you healthy. And if that means I lose you as a member, so be it. I did the right thing and I can sleep better at night.
There was and what's your take on AI and how it's now used, how it could be used in this new model of things coming together? Because they say, and I'm gonna get the percentage wrong, but it is AI is, I believe it's about 90% or 95% as effective at diagnosing what an illness is as a
Mhm.
doctor. So, for example, I got sick earlier this month, and rather than going into the doctor, whether this is good or bad, I don't know. But I just typed in my symptoms to ChatGPT, and as my symptoms changed, I was able to diagnose and figure out what I had and what I should do for it. And that cost me $20 a month. And what's your take on how things like that might come into play?
That's a very great question. We have to adjust with the times. AI is going to take over everything. I think AI in healthcare in the current state is going to take over more objective data than subjective. That being said, we can probably utilize AI and push in, okay, these are the lipid panel. This is the current liver enzyme. This is the renal enzymes. This is the thyroid. This is what the urine shows. Tell me what the likelihood of deteriorating kidneys in the next 10. Data, some objective. Another aspect, radiologist. I'm worried for radiology as a whole specialty because I can see AI really becoming better at reviewing radiology than the human eye. But anything that requires subject, anything that requires relationship, anything that requires a human brain to think through the disease process, I'm not worried about my job. I don't think we're always going to need that human doctor there because what AI is going to have a hard time differentiating is you between next patient, between your wife, between me, my nurse. Good at plugging in numbers, but the whole picture wise, it's not going to be able to tell that apart. And a lot of times the outcomes and getting to the root cause are so patient dependent. I can't even explain it. Why does a blood pressure medicine work for you versus the other person? Why do you do better if I add this medication on or don't add medication, work on your social, economic, or family life and mental health? How come that actually fixed a disease like blood pressure? And so it really, I'm not worried for it at all. I think we're going to make a very good partnership with AI. However, with how litigious the country has become, I think that's going to be something that's going to need very close observation on how that expands over the next 10 years. If it gets the diagnosis right, 99.9% of the time born, if it gets it wrong once, I can see it becoming a huge litigious issue.
For sure.
I think it's the future. I just think we have to walk on eggshells on how to get there. So doctors don't rely on it. One of the great examples I say why our job is pretty much secure is look, you come to 10 different doctors with the same complaint. You can get 10 different advice, outcomes, or recommendations. All 10 doctors have finished medical school. All 10 doctors have finished training in an ACGME accredited program in their respective institutes. Why do we get such different advice? Because it depends on your relationship with the doctor. It depends on what they feel, what they see. And AI can't do that
Right.
right
You
now.
you would still you would still want that informed opinion backing it.
Yes.
Because, for example, as of right now, AI is excellent, but it's still only as good as the person that's receiving it and how they're able to decipher that versus because if it contains inaccuracies and someone's not able to identify those, they could mistreat themselves. They could make a mistake. In some cases, not even have the right faith or certainty to even put it at a stronger sense that diagnosis is accurate. And that goes a long way when you have a trained medical professional who says, I can say with certainty that this is exactly what this is, and this is exactly the way we need to treat it, versus someone going, when you ask, so I typed in my symptoms, it gives me 7 or 8 different things. Maybe it's the old WebMD everyone used to use, but a little better. And I had to keep going and then update it and bring different perspectives as my symptoms change to finally nail it down and say, okay, I think it's this one thing. but not everyone is going to do that. Some people might just say, all right, here's my 8 things. I'm going to pick the one that's the scariest. Like people used to do with WebMD, where they would come in, and maybe they still do. They come in and they go, hey, I have this terrible thing. And the doctor needs to then walk that person back and go, okay, but what do you really have? Let's figure that out. You still want the human in the loop because we need to have the confidence and the certainty in what that really is, and someone who's informed and not just our reactive minds taking in what something is.
You need the human in the know. And this is where I go back to my mentor, Dr. Izikov, is I was straight out of residency at that point. That was my first job. And we relied on objective data because as residents, you saw thousands and thousands of patients. That's how you get good at your craft. You can't see 100 and call it a day. Look, we saw thousands and thousands of reports, radiology, lab tests over and over again. And then I remember watching Dr. Izikov work, and he knew his patients so well that when a patient walked into his office, he could tell right away if they were sick or not. And in the beginning of my career, I thought that was BS. And that's like where AI comes in is, yeah, you saw all the numbers together, you put in your symptoms. At the end of the day, I'm at the level now in familiarity with my patients. It's true. As soon as they walk through my door, I can tell, holy crap, is there something serious going on? Versus, oh, it's probably just a sign. Just by their facial complexion, just by the way they talk, just by the way they walk, just by the way their skin feels, just by the way they smell even, I could tell, is there something underlying, something more serious? Yeah, you can plug in all the objective data you want. AI is never going to touch and feel you, at least now. They're not going to form a relationship with you. You need that human touch. You're treating humans at the end of the day. So yeah, I joke. I was like, finally, I'm at the level I know exactly what Dr. Talb was talking about.
What can patients do to support the new paradigm of healthcare and maybe advocate for it? We talked about the regulatory and legislative aspects, which requires people to be aware of things like this, like through this podcast and other formats, people becoming aware of these things. But how could they begin to support these things and advocate for the proper changes necessary?
I truly believe nothing's going to change in this country unless money is involved. So the first thing that patients need to understand is that you guys are the business. This profession wouldn't exist. All these administrators, health systems wouldn't be building buildings left and right. All these big insurance companies will be taking bonuses of billions of dollars home every year if it wasn't for you. I had a patient come into my office just this week, and she was sick over the weekend. And I said, why didn't you call me? I'm on call for you 24/7. And she goes, I always feel that I'm troubling the office when I call. And it broke my heart. It really did, because that's how we have conditioned population to feel when they're sick, when they're at their weakest point. And I don't want to cry on camera, but this is not the reason why we went into this profession. This is what happens in the nation now, where a patient who's sick, who needs help, is afraid to call their doctor's office because they feel like they're begging for an appointment. They feel like they're troubling the doctor or the staff. They feel like they don't want to get told to go to urgent care, but they know they can't talk to the physician if they needed to. And that breaks my heart so much, because this conditioning didn't happen overnight. It happened over the last decade. It happened over the last 2 decades. And unanimously, this is the experience that every new member of mine tells me, because it takes them about 3 months in my membership to realize they can reach me, to realize I'm not going to get mad at, to actually utilize the membership to its full extent. Because as a physician, I want to be the first one to know if you're sick. I want you to call. But to have to recondition the general public and all these patients to feel like they're not bothering me, that's the real disease that's going on. So patients need to start advocating for themselves. Without you guys, the hospitals would crash. Without you guys, you wouldn't be in business. So really advocate for yourself. Find alternative practices out there where you're treated like a human being instead of a number. Realize that a lot of practices, including me, aren't that expensive. You're paying for NFL ticket. You're paying for YouTube TV. You're paying for this membership, that membership, but gym membership you never used. The one membership that you should pay, you should invest in, is your health. And That's my advice. You got to advocate for yourself because unfortunately, in this current healthcare system, nobody's going to advocate for you. You got that 10 minutes with the doctor. Their incentive is to get out, go see the next patient, get you out of the door as soon as possible so they can bill the next patient, etc. I value every single one of my patients. And yeah, I'll tell this over and over again to anyone I speak to. It really breaks my heart for patients to feel bad about reaching out for help with their doctor. And I think that's my biggest prerogative. I wish there was more primary doc specialists that would reach out and do this model because we're in the business of helping people. And I think we lost our way a long time ago and we need to get back.
For sure. What about physicians to be, people that are in the system as of right now? Because likely something like this may take a decade, 2 decades to really, from top to bottom, transform and be new. So how about someone that's in the system right now? How could they begin to support and encourage and advocate for these kind of changes?
Educate. If you are early in your career, if you're a medical student, if you're thinking about going to medical school, if you're in residency, before you finish, before you sign that big 5-year contract, look at what different other models of practices out there and go talk to those docs. I have, since I started, I want everyone to know we've only been open for 3 months. Since I've started, I have countless doctors and mid-levels asking me for advice, asking me for help to try to get them out of their current situation, join and start their own practice like this, or even form a group practice like this. Because I truly believe no doctor went and gave up their prime, got signed on to all this financial burden to make money. I think they all just want to give the best care to their patients as possible. Do your research, educate yourself. The saving grace is my model and this current movement of concierge and direct primary care, direct specialty care even now is really making a boom. So by the time you finish residency, by the time you finish med school, we may be in a different place than when I finished. And that's the silver lining I look for.
It's exciting to me to think that this major problem that everybody knows about may have a nearer term solution than we may think. So, for those who have now listened to this, what is the one takeaway, one action that they can do? I always like to end with an action that people can take. It's great to listen to it, it's great to hear, it's great to be aware, but an action is everything. So, what is one thing that everybody could do right now today to help support this?
I'll answer that in 2 categories. If you're a patient, like I said, advocate for yourself, do your research, read your reviews, change the mentality that you're just not a number. Change the mentality that without you, the field of medicine wouldn't be as profitable as it is. Educate yourself on different insurance plans. Educate yourself on different concierge practices. Do an early investment in your health. Health insurance is one of the few insurances where if you think about it in the long run, you're betting against yourself, right? How long have you been paying into health insurance that you didn't utilize? Why are you paying into it? Because you're betting against yourself. What if I have that heart attack? What if I get that cancer? What if I have this really expensive treatment? If you're healthy, you're never going to utilize any of that. So rather than investing against yourself and betting against your own health, put some of that money into a more location-centered, focused practice that will keep you healthy in the long run so you never have to utilize it. Change your mentality on your health. That's my advice for the patients listening in the audience. For investors, for businessmen, think about reaching out to startup direct primary care concierge practices. Find a doctor or a business owner that's really passionate in the long run and invest in health and grow. Because I can tell you, I make good money doing this and my patients are more satisfied than ever. And docs aren't in it for the money. There's been countless studies to show that once you make a certain salary, every number above that decreases your quality of life. I don't want that. I'm perfectly happy with what my goal salary is. What would make me more happy as a doctor, as a person, is really pushing this model forward, giving better care to the general public. And unfortunately, like I said, a lot of doctors don't have the financial backing as a lot of investors do. Find your local guide, find your local doc, talk to them, look over their business plan. See if there's any ways you can help promote this in a bigger picture, because over time, as you get more doctors into this model, healthcare is going to have to change. When hospitals start losing doctors left and right, they're going to have to change. That's my advice for the two types of listeners.
And then how can people get over the fear of not having insurance? Or should they still have insurance to some degree? What do you think about that?
Great question. I want you and everyone here who's general to calculate how much they put into insurance in the last 10, 20 years and how much they actually capitalize on it. Let's say when I was working at the health system, for me and my family, it was roughly 1,000, 1,500 a month, which is roughly 20 grand a year. And let's say nothing happens in 10 years. You would have put in $200,000 into insurance. Then you would have went to see a doctor 2 to 3 times and all the other times got sent to the urgent care, which you still needed to pay a copay.
Right.
Or prescribed amoxicillin, which insurance said they covered, but if you paid cash, it would have been $5 anyways. So majority of people, 10 years, spend $200,000 into insurance and never had a heart attack, never had a brain tumor, never had breast cancer that needed chemo for 4 months or surgery on top of that. You just lost $200,000 you could have put into anything else. Insurance is needed. You'll have to look at what your current health situation is. You have to look at your age. It's a multifactorial, but there's also different kinds of insurances out there. There's high deductible insurance, like that ER visit, right? If you have a $6,000 deductible, $8,000 deductible, your monthly premium would be low. And you can use whatever you save to get yourself a own private doctor for you and your family. So you'll never have to use that deductible because you're well taken care of. You never have to pay copays. You're seen when you need to be seen. But you have that catastrophic insurance in place where if you go to the ER or get hospitalized, that deductible is going to get met within the first 8 hours when you stay there anyways. So everything on top of that is covered. A lot of my patients have transitioned their insurance to a high deductible insurance because they knew even when they were paying for a low deductible, they barely ever used it. And when they did use it, they didn't get to see the person they want to and got stuck with a copay. And they still had to pay out of pocket for a lot of other things as well. And whenever they got close to that deductible, the year rolled over and to zero again. So a lot of my patients adjust to that. There's also health savings plans, HFAs, that you can use to pay for any kind of health service, including private doctors. There's community care plans where it's basically like a community high deductible insurance plan that you can get into. So you have that reassurance if anything major happens, but you also save money that you can put into practice like this because you have access to prevention, bettering your health. You never have to capitalize on that catastrophic part if it ever happens.
So taking a more thoughtful approach to your healthcare that's objective and rational, and being willing to bet on yourself, really,
Yes,
and invest in yourself.
exactly.
I mean, imagine how much you could do with $200,000 if you invest that into your health.
That's 10 years. So I talked to a patient of mine who's 75. We paid into insurance for 35 years. And we did a rough calculation and it was mind blowing. And the funniest part of this is, we might save this for another episode, is how insurance works. Let's say over 35 years, this guy put almost 500,000 to 700,000 into insurance. He never had a heart attack. He never had cancer. He never had anything. But he asked me, what if I didn't have insurance and got a heart attack? And I said, let's say you didn't have insurance, but you saved 500,000, right? And all of a sudden you had a heart attack. We go to the hospital, get admitted, you get that stent placed, the cardiologist, you get medicine prescribed, and you leave that hospitalization and tell the hospital you don't have insurance. They're going to give you a very reasonable bill. They're going to give you a cash pay option. And that kind of cash pay option, let's say if that whole visit cost insurance $100,000 and they knew that you were cash, the hospital may charge you $20,000. Why? Because that's $20,000 guaranteed in the pocket for the health system rather than waiting for that 50% reimbursement that might come a year from now. The other thing I would advise patients is cash is king. Go look at certain procedures, go look at certain offices, look at certain surgeries that are elective and see how much cash would be. Sometimes the cash price of that surgery or procedure might be less than what your deductible is. If your deductible is 8,000, the surgeon might say, "Oh, you're paying cash. Here's 4,000. We'll get it done." You're going to have to pay that anyways. You might as well pay less. So it's very shocking how far cash can go in healthcare. And you could probably take a whole episode just talking about that.
That'd be fantastic. Yeah, that and also some of newer medicines and looking at some of those kind of interventions would be great to talk about in the future as well.
Wonderful.
Fantastic. Dr. D, it's been a pleasure to have you on the podcast. We're keeping patients
You
alive
don't want
here.
to, sure, yeah, you don't want to go see a doctor die. That's for
Right.
very happy to be here. I'm glad I got my message out to everybody. We're located in St. Augustine. Again, it's Paradigm Primary Care. Whether you're a patient, whether you're or a businessman or a group who want to pick my brain anymore, you can contact Jacob or you can contact me directly. I'm more than happy to chat.
Excellent. Doctor, thanks for being on the show.
All right, take care.
Hey everyone, thank you for watching this episode of Titans Up today. What did you learn from it? Make sure to drop a comment below with your most valuable insight so that other people can engage in the conversation around what this speaker brought to the table. And then on another front, make sure to subscribe so that every time we drop a new episode, you will be notified. And that way you can keep fueling your dreams and your brain with fresh insights which can help you along your journey and along your path to your goals. So thank you so much again, and I look forward to seeing you in the next interview.